Everyone comes later, like every single time.
Really?
Yeah.
Last time I went here, like, in this area, there were heaps of people.
Oh, I hope more people turn up. More people. It's only 6:50. People turn out for like way late.
Yeah. I finished at 12:30 or 1 today, and I was thinking, so I come on them.
Hmm. There you go.
It's recorded.
Yeah, I'll cut it out.
Thanks.
Like the Mulo recording only starts at 6. So.
I think it is. Is it back up?
For live stream, yeah, Mulo's back up. This is the first lecture that I think he's got in front of me. Okay. And like last time, the broadcast just stopped after 1 hour.
Yeah. Oh, yeah. Right.
And it is awful. What rotation would be? Oh, that'd be fun. Yeah. There's no baby coming in, so we need to worry about competing. You won't get the yeah, I would do that. They banned all students from Eastern Hall. So unless they change the rules. I know, so it sucks being a baby, but just got 30 years or 4 years as well. But like years ago, right? Yeah. So yeah, so it kind of sucks. It's like if they there was something in school Boston to do. And then they were like, oh, no, students are like, yeah. Yeah, so we do. Yeah, well, it's not the timing.
Yeah, it's short.
I think it'd probably be like a little bit smaller. And Japanese more trauma, so it'd be less exciting.
How's the business?
It'd be like
Which one?
The bigger one.
Oh, JP Brendan. Yeah, it was okay.
It was then,
I could tell. How was the marking for that?
Lowest of it. Oh, 3.
Mm.
But still reasonable.
It has ED, but
Who might be honest?
Jennifer Neal. She's like, he was only there for that.
I had looked at it. It's because my place there.
Yeah.
They don't specialize in healthcare.
When did you get eyebrows?
Like one of the healthcare teams was
When did we get it? At the Alfred, we got it back before the rotation ended.
Yeah, that's what I heard from all our sides. Like what, week 9?
Yeah, week
I don't think I've ever seen them get into
9.
like
It's true.
chain sex breathing.
What? Yeah. The cycle bullet.
Yes. So I heard.
From who?
Is that the one thing?
Hey, hello.
I heard a consonant didn't like specific names to say someone else. It's true.
Oh no! Was he really old.
What's this? Keep doing.
Like, really, like,
No idea.
like,
Okay, let's see if this works.
it's not like he was. Yeah, but like. It's like, shock. You just want to feel something.
Do you go to primary school?
No,
Where do you go?
just Glenwelly South Primary School.
So Damien?
Damien. Who's that? Damien who?
Damien, good question. Where's your phone? How you feel about friend with him on Facebook? Just someone from the gang. Just someone from the gang.
Hey Jim. How are you?
Fine, yourself?
Not too bad.
Setting up recording?
Yep. I think it's working this time.
Yeah, there's been a couple audio issues in the past. What are you using to record? So like you're actually using the theater system or?
No, it's just using the microphone from the.
Okay, sure. Alright.
But I think so. Fingers crossed.
What you trying to do?
Put it back.
Need help? Nope.
Cool. Okay. It's working. Alright.
Grab a seat.
Yep.
I have no idea where to sit.
Oh, well, I'll need to introduce. Yeah. There'll be more.
One more for you.
Yeah, give us a call. Usually it's been like it hasn't been, yeah, it hasn't been too like so field, but like it was.
Yeah.
Yeah.
Yeah, so that makes sense. I went to blushing. Oh, yeah, sounds kind of shaky. It's like they're crying.
Good. How are you? Good. How are you? Yeah. Well, it's 4+6. Yeah, yeah.
So do I just click on my own?
Yeah, if you just like use the arrow
and
keys.
this,
And if you,
like if there's notes, it comes up.
yeah, it should.
Oh, sweet, because I like to do this now. I was like, I knew I'd just like forget about it.
Yeah, no, all good. You can just use the arrow keys as well.
Yeah, awesome. And do I don't need to stand really close? Or?
Yeah, I don't think you do. Yeah.
So like there's heaps of
Yeah, that'll be all good. Yeah, I might just give you a bit of introduction. Yeah. All right, guys, we'll make a start. So thanks for coming along to today's revision lecture. Today we've got abnormal menstrual bleeding and Gynaeonc with Erin, so make her feel welcome.
Hey guys, yeah, so as Dinesh said, I'm Erin, and thanks for coming along on your Monday night. So we might as well get started. So, just a show of hands, who's done their women's rotation? Okay, so most of you haven't. Okay, good to know. Okay, so just what we're going to cover, quickly cover normal menstrual bleeding. We'll go over all the different types of abnormal bleeding, and we'll cover the three main Gynaeonc conditions, so cervical, endometrial, and ovarian cancer. So just to recap, normal menstrual bleeding, it's about 21 to 35 days for a cycle, and it's usually about 5 days of actual menses, with a total blood loss of about 25 to 80 mils. I'd strongly recommend knowing this diagram really well and understanding kind of what it's showing. So do I have a mouse here? Yeah. So, oh, wait a minute, here we go. So, so what this shows is, so this is when you're having the menstrual period, and then during the first 2 weeks, estrogen rises, which causes the LH and FSH surge, which then triggers ovulation. And then if the egg isn't fertilized, that turns into the corpus luteum, which produces progesterone. So that's when you get this progesterone peak. And then with the actual endometrial lining, so when you've got lots of estrogen around, then you get proliferation of the endometrium, which becomes quite important when we talk about endometrial cancer later. And then the progesterone kind of stabilizes the endometrium and it becomes what they call a secretory endometrium. So just to go through some terminology, so can someone tell me what abnormal uterine bleeding means?
During the normal bleeding period, or period.
Yeah, so that's part of it. So abnormal uterine bleeding is this term that you might get heard thrown around and no one really explains it. And it's something that kind of once some, I don't know, gynae association or something came up with. So it kind of incorporates heavy menstrual bleeding and intermenstrual bleeding. To be honest, I don't think it's very important for you guys to just, I suppose, be aware of the term if you hear it. But the terms below are more important for you to kind of understand and be thinking about when you go into your OSCEs. So what's heavy menstrual bleeding? Pretty self-explanatory. Yeah. So that's the technical definition. Really, when we talk about heavy menstrual bleeding, is if it's kind of disrupting the woman's social activities or work activities, or it's heavy for her, then we don't be like, oh, well, it's only 79 mils, get over it. So amenorrhea, what are the 2 different types? Yep. So what's primary amenorrhea? Yeah, so never ever had a period. Yep. And so secondary amenorrhea is someone who's had normal, regular periods and then for whatever reason they stop. I think it's more than 6 months. If they stop for more than 6 months, then you would call that secondary amenorrhea. Oligomenorrhea.
That's the expected amount?
Yeah, so it's more, so it's not really in terms of volume, but more the fact that it's more than 35 days apart. So we said this normal cycle is 21 to 35 days. So if they're more than 35 days apart, because you can still get a heavy oligomenorrhea. And polymenorrhea. Yeah, great. Intermenstrual bleeding is kind of what you mentioned before, so bleeding in between the cycles. And postcoital bleeding is again what it sounds like, so bleeding after sex. So we'll talk about heavy menstrual bleeding. So this is now the more correct term for menorrhagia. And as you said, it's more than 80 mils of blood loss per cycle. But clinically, we really use it just to describe excess volume or duration of bleeding. So who can tell me some differentials for heavy menstrual bleeding? It's more dysmenorrhea, but maybe. Yep, good. That's one of the most common, fibroids. Yep, hypothyroidism. Yeah, it can. So it can cause like a heavy oligomenorrhea. So have a look. So I divide it into uterine causes, ovarian causes, and then kind of systemic things. So for uterines, as you said, fibroids. So usually these are the submucosal fibroids. Adenomyosis. So endometriosis doesn't usually cause heavy menstrual bleeding, but adenomyosis, which is endometrial tissue that gets deposited in the myometrium, so the muscle layer of the uterus, that can cause heavy menstrual bleeding as well as dysmenorrhea. Pelvic inflammatory disease, the copper IUD, and endometrial polyps and cancer. So then there's anovulatory causes. So can anyone explain to me why someone who's not ovulating gets heavy periods? So if we remember back to the diagram that we looked at the start, so when you have high levels of estrogen, you get proliferation, and if you ovulate, then you get progesterone from the corpus luteum. If you don't ovulate, you don't get that progesterone, and you still kind of have unopposed estrogen, so the endometrial layer will keep proliferating. So people, so in the first 12 months after menarche, girls often don't actually ovulate, even though they're having their periods, and they might be a bit heavier. And similarly in the perimenopausal period, and then PCOS, in which they might, even though they might be irregular and not having periods very often, when they do, they can be really heavy. Systemic causes, so hypothyroidism, and then just things like coagulation disorders, if someone's on anticoags, and any kind of estrogen things, so exogenous estrogen or tamoxifen. So if you go into an auscultation and the stem is someone who's presenting with heavy menstrual bleeding, what you want to look at on history is if you want to do a full menstrual history, so asking about their cycle, whether it's regular, irregular, if there's any pain, and then you want to quantify the menorrhagia, or the heavy menstrual bleeding, I should call it. So what kind of questions would you ask to quantify? Yep, good. Yep, perfect. Yeah, that's a really important one. And you will, when you do your women's rotations, hopefully come across people that actually does affect. Yep. So as you said, frequent changes of pads or tampons, flooding. So things like if they're needing, to wear 2 pads and a tampon to bed and a towel under them, otherwise they'll get blood on the sheets. Passing clots, missing work, school activities, and you might want to explore, if you have time, any kind of anemic symptoms. And then, as with every women's history, you want to do asking them about pregnancy and previous obstetric history, when their last pap smear was, and the usual past medical, family, social history and medications. So then, as you might or might not yet know, in your OSCEs in 4th year, you're pretty unlikely in a women's OSCE to be asked to actually do an examination, but you might be asked, what would you look for? What signs would you look for? So these are some of the things you might say. So you might say signs of anemia, any vital signs, looking at the thyroid if you're thinking it could be hypothyroidism. And then you would, of course, palpate the abdomen for any masses, so which could be fibroids or cancerous. Then you would do a vaginal examination. So first up, you would do a speculum. At that time, you would do a pap smear if they haven't already done that, which you would have already asked in your history, if they're due for one. Swab for any pelvic infections, if you're thinking maybe they've got pelvic inflammatory disease. And then you'll do a bimanual. So some of the kind of fuzzy words, like a bulky, tender, boggy uterus would be adenomyosis, and a bulky, antiverted uterus would be fibroids. So what investigations might you want to do in someone with heavy menstrual bleeding? Starting with bloods. Yep, so an FBE. Iron studies, yep, good. Probably one more main one. Yep, you could do that. Yep, good. Yep, and imaging. Yep, good. So pelvic ultrasound. That's probably, yeah, that's it. So on pelvic ultrasound, you might see fibroids. Again, another buzzword for adenomyosis, thickening of the transition zone with a Venetian blind pattern of acoustic shadowing. And you might see polycystic ovaries. Any other special tests that you might do? Someone that's been on women's. So Papel sample, which is essentially a biopsy that you take in just in the doctor's rooms. So it's kind of a blind biopsy, and you can't really see like where the mass is, and to make sure you're taking it from the actual mass. Does that make sense? Yeah. And a hysteroscopy D&C, which is an operation under general anaesthesia. So they look with their hysteroscope down into the uterus, and they can take a biopsy, or it's kind of like a, for want of a better word, like a scraping. And when they do that, they can actually see what they're looking at, and if they see any suspicious areas, they can make sure they're taking it from there. So this is the Venetian blind appearance. You wouldn't be expected, I don't think, to recognise it on an ultrasound, but they're really just talking about those kind of dark lines that you can see kind of through here. And someone with a really good imagination thought that looked like a Venetian blind. So, okay, so for management, you're going to treat the underlying cause, and then your first kind of thing would be to do medical treatment. What kind of medical treatments do you know of for heavy menstrual bleeding? Yeah, great. So that all goes back to that diagram at the start. If you put in progesterone, you're going to stabilize the lining and make it thinner. Yep. There's also some non-hormonal things, so non-steroidals, particularly mefenamic acid, and then tranexamic acid can also be used, which is an antifibrinolytic. Some hormonal things, so you could use the pill, although a lot of the time these women are a bit older, so they might be in their 40s, so you would think really consider the VTE risk, so this wouldn't be your first line. In fact, a gynaecologist said to me when I was in 4th year, it would be surgery and then the pill, like that would be the order you would consider. So the most common used thing is the Mirena. So that's the progesterone intrauterine device. Then for surgical treatments, so you can do an endometrial ablation, which is literally either thermal or laser ablation of the endometrial lining. And so it essentially just prevents it ever growing back. So important to note that's not conducive with fertility, as obviously a hysterectomy is not conducive with fertility. If someone does want to, if they have fibroids and they still want to have children, you can consider a myomectomy, which is literally just cutting out the fibroid. So just quickly, we'll talk about dysmenorrhea. So there's, again, 2 types, primary and secondary. Primary is generally not pathological. So this just starts usually about 12 months after menarche when the girl first starts ovulating. And then secondary dysmenorrhea is generally pathological. So that's someone that's not had dysmenorrhea or had quite mild dysmenorrhea and then all of a sudden gets quite severe dysmenorrhea. So what are some differentials for secondary dysmenorrhea? Yeah, good. That's the main one that you probably want to think about. Yep, good. So they're the main two really. And the other one is adenomyosis, which will also present with heavy menstrual bleeding. So on history, you just want to take a normal pain history and then you want to ask questions to rule in and out all of those differentials. So, you know, history of STIs, history of infertility, which occurs both in endometriosis and PID. Yeah, and then on examination, so things that you might find is a fixed retroverted uterus, which is due to adhesions, and that's usually an endometriosis. And then something called cervical motion tenderness. So when you do a bimanual and you palpate the cervix and kind of move it, it will be very painful, as well as uterine tenderness and adnexal tenderness, which you get in pelvic inflammatory disease. Then on investigation, you might do a high vaginal swab, again, if you're suspecting STIs. You might do a pelvic ultrasound, and then for endometriosis, the gold standard is a diagnostic laparoscopy. In terms of management, again, you can use NSAIDs. So it's the anti kind of prostaglandin effect that works there for dysmenorrhea. Again, you can use hormonal things, so like the Pure or the Mirena. And surgical options is diathermy and excision. So that's literally just kind of diatherming off the little endometric deposits, or a hysterectomy. But if you do a hysterectomy, you still want to make sure that you kind of diathermy any other nodules outside the uterus, so they can have them anywhere in the peritoneum, or technically anywhere over the body, but usually they're in the pelvis or the peritoneum. So you want to diathermy that as well, otherwise they're going to have a hysterectomy and still have pain. Any questions about that or heavy menstrual bleeding? No? Cool. So again, just quickly we'll talk about amenorrhea. So there's primary and secondary. So who can tell me some causes about primary amenorrhea? Yep. Yep. Yeah, yeah, yeah. Yep. Yep, good. What was that, sorry? Oh, yep, yep, good. Yep, so you've got most of them. So I divide that into reproductive tract things, so kind of anatomical things, so the imperforate hymen, Müllerian agenesis, which is, so the Müllerian system is the kind of embryological structure that becomes the female reproductive tract, and the transverse vaginal septum. Then ovarian things, so Turner syndrome or PCOS, and pituitary and hypothalamus causes. So as you mentioned, you know, someone who's an athlete, like a ballet dancer, low BMI, or has an eating disorder, people with congenital adrenal hyperplasia, pituitary adenomas, so particularly prolactinomas, can cause amenorrhea, and just emotional stress or chronic disease. Hyperthyroidism, so like hypothyroidism causes heavy menstrual bleeding, hyperthyroidism can cause amenorrhea. And Kallmann syndrome, which is a hypogonadotrophic hypogonadism. Yes. So it's a genetic kind of X-linked recessive disorder. So it's more common in males, but females can get it and they'll present with primary amenorrhea. What about causes of secondary amenorrhea? So some of them will be the same. Yep. Premature ovarian failure. Yeah, so you like someone might present to you, and you do have to think of menopause, and I suppose in the same vein, premature ovarian failure. Yep, so you're always going to consider if they're pregnant. Okay, so I divide it the same way. So with the reproductive tract, there's something called Asherman syndrome. Does anyone know what that is? Yeah, usually caused by what?
DNC.
Yeah. So people that have had a DNC, so for a hysteroscopy or for abortion, so they can get scarring and the lining literally just sticks together. So it's almost, I suppose, like having an endometrial ablation, but not really. Yeah, and then they can get amenorrhea. So again, it could be PCOS, could be premature ovarian failure, and most of the pituitary and hypothalamus causes are the same, except for, again, there's something called Sheehan syndrome. You can tell me what that is. Yeah, who said that? Yeah. So, and what's the kind of common thing that they describe that causes that? Yeah, so a really big postpartum hemorrhage causing kind of hypovolemic, like hemorrhagic shock, which causes infarct of the pituitary. Yeah. And craniopharyngioma, which is just a tumour in the hypothalamus. So to investigate amenorrhea, so again, it depends on the clinical suspicion of the cause, but you would do a beta-HCG to make sure they're not pregnant. And then your bloods, so you do all your kind of sex hormone bloods, so your FSH, estradiol, prolactin, and your androgens. Again, you do thyroids, looking for hyperthyroidism, and imaging, so pelvic ultrasound, MRI pelvis. I'm not really sure in what situation you would do that, but and an MRI brain if you're thinking about pituitary adenoma. So when you get someone present with primary amenorrhea, you want to think about whether or not they've gone through normal puberty otherwise. So to do that, you need to know the sequence in which things usually occur. And it can be an exam question that they ask the order, or, you know, if someone's of this age, what would you expect them to have gone through in terms of puberty? So breast development is first, and that can usually starts to occur around 10 to 11. And then pubic and axillary hair growth from the adrenarche. Then they will get a growth spurt, and last is menarche, so around 11 to 14 years old. Okay, any questions about amenorrhea? So moving on to postmenopausal bleeding. What are the differentials for postmenopausal bleeding? Yep, great. So that's the thing that you want to rule out. It's a thing we worry about, but it's usually actually not what causes it. Yep, good. Yep, exactly. Yeah, good. So that's a really common one. Cool. So again, divide it into endometrial, cervical, and vaginal causes. So we said endometrial hyperplasia. So that's caused by unopposed estrogen. So someone who for something like this shouldn't happen, but if they were on HRT and they were just on estrogen, endometrial polyps can cause postmenopausal bleeding, and as you said, endometrial cancer, that's what we really worry about and what we investigate for. Cervical, so again, cancer or polyps, and vaginal causes, so atrophic vaginitis. So for those of you who haven't done women's, you might have come across it in GP, but it's literally kind of a drying out and thinning of the vaginal wall that happens in menopause, and can just be treated with like an estrogen pessary. And again, vaginal polyps and cancer, which is very rare. So now we'll just segue into endometrial cancer. So endometrial cancer is just one type of uterine cancer, but it is the most common, and it's really the only one you need to know about. But just be aware that there are also sarcomas, so cancers in the myometrium. And of endometrial cancer, the most common is endometrial adenocarcinoma. So we know that there's a clear association with high levels of unopposed estrogen with endometrial cancer. So keeping that in mind, what are some of the risk factors for endometrial cancer? Yes, good. Yep. It's good. Yep, good. So fat cells make estrogen. Yep. So if they were only on estrogen and not the progesterone as well. Yes. Yep. So the longer you're having ovulation and periods for, like the higher estrogen levels. Yep. Pardon? Yeah. Yeah. I was like, I can't think of any examples, but okay. Yep. Okay, good. So, yeah, as you mentioned, PCOS, obesity, diabetes, null parity or infertility. So if you don't have like kind of that break during pregnancy, late onset menopause and early menarche, something called Lynch syndrome. Does anyone know what that is? Is it clue? HMPCC. Yeah. Do you know what they are? The most common ones? Yeah. Yeah. So just in case everyone didn't hear that, so it's a hereditary condition which predisposes you to a number of different cancers. So the first is hereditary non-polyposis colorectal carcinoma, so bowel cancer, as well as ovarian, endometrial, and I think breast cancer. Pardon? Possibly. Like there's a lot of different ones, and there's some that are more common than others. So yeah. And then estrogen only HRT and tamoxifen. So endometrial cancer, as we said, can present with postmenopausal bleeding, and it is most commonly in postmenopausal women, but it can less commonly occur in premenopausal women, and they might present with heavy menstrual bleeding, intermenstrual bleeding, blood-stained vaginal discharge, pelvic pain just from the kind of mass effect, and dyspareunia. So, and rarely, if you do a pap smear, it can pick up abnormal endometrial cells, and which goes on, like you get further investigation and it could pick up endometrial cancer. So, in terms of investigations, you'll do a pelvic ultrasound. What's the magic number that you want to, what are you looking for on pelvic ultrasound?
6 millimeters.
Yeah, so I think I say 5, but yeah. So you want to know whether you want to look at the endometrial thickness and whether it's more or less than 5 millimeters. So if it's more than 5 millimeters, that's thickened in a postmenopausal uterus, and therefore you have to go on to investigate it because it could be endometrial cancer. So that's so kind of this bit here, or the kind of lighter bit is the endometrial lining that you're measuring. So if it's more than 5 millimeters, the next thing you do is an endometrial papel. So again, that's the kind of just in the doctor's office biopsy. So usually you wouldn't do that unless maybe like the only circumstance I saw that done was in an elderly woman who wasn't fit for surgery. So they were never really going to do anything about it anyway. So some argument that if you weren't going to, like, why would you do the papel at all? But that's what they did. And then hysteroscopy DNC. So then if you diagnose endometrial cancer, you want to do some staging investigations. So you'll do your basic bloods, FBA, UEC, LFTs, as well as you do with any cancer, a CT, chest, abdo, pelvis, looking for any metastases. So management of endometrial cancer is primarily surgical. It's usually picked up reasonably early, and that's a total abdominal hysterectomy and bilateral salpingo-oophorectomy. So essentially you're taking out everything, and that's plus or minus a pelvic lymph node dissection and a para-aortic lymph node dissection. So if you can just, I suppose, blurt out the total abdominal hysterectomy, bilateral salpingo-oophorectomy in an OSCE, then maybe practice saying that. So then some people might have radiotherapy, so that's been shown to prevent local recurrence, but it doesn't actually improve overall survival, so it doesn't help with whether that recurrence is going to metastasize or not. And then chemotherapy is really just for those with distant metastases or those you think are really high risk for metastases. So if the tumour is of a high grade when the pathologists look at it, if there's deep invasion into the myometrium, if it's not an endometrial tumour, so if it's one of those clear cell carcinomas or something like that. Yeah, so as it says underneath, so if it's a papillary serous adenocarcinoma or a clear cell carcinoma, not the usual endometrial adenocarcinoma, then you would think about giving chemotherapy. So by all means, you don't need to remember this, but just to show, so most people are picked up pretty early, so in stage 1 or 2, and there's pretty good survival for endometrial cancer. Okay, any questions about that? Okay, so moving on to differentials for postcoital or intermenstrual bleeding. You can tell me. Good, yep, that's probably the main one you want to think about. Yep, so STIs. Yep, okay. So when you have someone with postcoital or intermenstrual bleeding, so those of you who have done GP, you've probably noticed, well, your GP should be asking whether they have either one of those when they come to have their pap smears, because that raises your suspicion of cervical cancer. So as well as cervical cancer, there's vaginal cancer can also cause this, but again, that's really rare. Vaginal atrophy, STIs, and cervical ectropion. Does someone know what that is?
So that the glandular tissue is more towards the outside of the skin.
Yeah, yeah. So I think I've got a picture next. So yeah, so this is looking at the cervix as you would look at it with from a pap smear. So this kind of glandular, darker pink tissue in the middle is the endocervix. And in younger women, which is when cervical ectropions happen, this kind of bit comes out really wide onto the cervix. So that's in high estrogen kind of environments. And then in menopause, it kind of regresses into the endocervix. Okay. So some things that might cause intermenstrual bleeding but wouldn't really cause postcoital bleeding is breakthrough when someone's on the pill, and endometrial cancer and polyps as well. So we've kind of gone through that. The only other thing to mention is, so the zone between the endo and the ectocervix is where cervical cancers and precancerous lesions occur. So that's the area that you take the pap smear. So just moving on to cervical cancer. So as you probably know, it's usually caused by HPV or human papillomavirus. So what happens is if someone's infected with that, they can clear the infection and that's fine. So it doesn't have any kind of lasting consequences. But if they don't clear it and they've kind of got a chronic inflammation there, that can progress to a precancerous lesion. Again, the body can the immune system can fight that and pick that up, and it can regress to a normal cervix, or if it doesn't, it can become cervical cancer. So the current guidelines for screening for cervical cancer is still pap smears, but have you guys heard about the new changes? Yeah, so I think you guys still need to know the current guidelines, but next year the HPV testing will come into effect. So for now, it's every 2 years women should have the pap smear, and that's starting from 18 to 20 years old, or 2 years after first having sexual intercourse, whichever is later, and up until they're 70. So someone have a pap smear can come back normal or abnormal. If it's abnormal, this is what it could come back as. So there's low-grade squamous intraepithelial lesions, which is, there's old terminology, which is CIN 1, 2, and 3. So that's equivalent to CIN 1. And then there's high-grade lesions, which is CIN 2 and 3. And then you can also get, less commonly, an adenocarcinoma in situ. So if it's a HSIL or an adenocarcinoma in situ, they need to be referred to a gynecologist and have a colposcopy with a targeted biopsy. If it's low grade, if they're more than 30 years old and they have had positive pap smears in the past, or they haven't ever had any pap smears before, then you would still refer for a colposcopy or repeat the pap smear in 6 months. But for everyone else, which would be the vast majority, you just repeat the pap smear in 12 months instead of 2 years, because often the low-grade lesions actually just regress and don't ever eventuate into anything. So if you do that in 12 months and it's resolved, you return to 2 yearly pap smears. If it's unresolved, then they go on to have a colposcopy plus or minus a biopsy. Does that make sense? It's kind of something you just have to probably sit down and make sure you've got your head around, which is annoying because then it's going to change. Then, so when they have their colposcopy, this can confirm a low-grade lesion, could show that there's nothing there anymore, or they might have a high-grade lesion. So even if they've had a high-grade lesion on pap smear, they could go and have their colposcopy and have a low-grade lesion, and vice versa. But the colposcopy with the with the biopsy is more accurate. So if they confirm a high-grade lesion, there's two options for the biopsy. So first up, do you know how they tell before they do the biopsy, like what testing they do on the cervix? Someone that's been on women's. Yeah, so it's like a vinegar or iodine stain, and essentially it turns the abnormal cells white, so you can see kind of the pattern of the abnormal cells, and from that they can tell whether it's abnormal and whether it's low or high grade usually. So if it's high grade, they do, you can do a cone biopsy, or you can do a LETS, which is a large loop excision of the transformation zone. Do you know what patient groups would do which in? It's got to do with the anatomy of the cervix, whether if you're kind of younger or if you're postmenopausal. Yeah, exactly. Yeah, so usually, so in younger people, so firstly they have high estrogen levels, so their transformation zone is going to be on that outside bit of the cervix, so you don't need to do a cone biopsy. And also you don't want to do a cone biopsy because it can cause cervical incompetence, which can cause like miscarriages or premature labour. And then cone biopsy you do in postmenopausal women, in which when the endocervix is kind of deeper within the cervix, so you have to do a cone biopsy to make sure you get that transformation zone. So if they have a low-grade lesion, they have to have another colposcopy in 6 months, and after that most, so 60% will resolve. If not, they will then probably just have a biopsy. If it's confirmed, and then they have their biopsy for a high-grade lesion, so they have to have another pap smear and colposcopy at 6 months, and then they have annual pap smears and HPV testing until both tests are negative for 2 consecutive years. Then they can return to their 2-yearly pap smears. That's like quite a lot of information if you've never heard it before. But yeah, again, just sit down and have a look at it. It's all on the Red Book GP site. Cool. So this is, yeah.
Do you think you'd be asked them to ask you exactly the guidelines and how a person should be referred or something?
I reckon that would be pretty mean, OSCE. There are some EMQ questions that are like, someone had a pap smear, this is what happened, like what's the next step? So you do need to know kind of what to do with a low grade and a high grade lesion on a pap smear. But yeah, I've never really seen, I can't think of seeing any questions or OSCEs about those specifics. Yeah, good point. Yeah. So this is just meant to demonstrate low grade, high grade lesions. I'm not very good at pathology, but essentially the nucleus gets bigger and the cytoplasm gets smaller and it's more disorganized. And then when it actually breaks through that epithelial lining, it's cancerous because it's invading. So we now have the HPV vaccination, which is a free national school age vaccination for males and females, 12 to 13 years old. They have 3 vaccines, and ideally you want to complete that before their first sexual contact, which is why we do it so young. But it doesn't remove the need for cervical screening. So who can tell me what HPV strains are the most common? So the ones that cause warts. Yep, 6 and 11. Yep, and which are associated with a high risk of cancer. Good. So there's 2 vaccines can't actually remember which one is which. One of you might be able to tell me, but there's Gardasil and Cervarix, and one of them has all 4 strains in it, and one of them just has the cancerous strains in it. 4, thanks. So in terms of presentation of cervical cancer, so usually it's abnormality on a pap smear, so it's quite picked up quite early and it's asymptomatic, but they can present with postcoital or intermenstrual bleeding, which was why you ask about it before you do a pap smear. You can present with postmenopausal bleeding or blood-stained vaginal discharge. When you do the pap smear, you want to look for contact bleeding. So that's when you literally take the pap smear. When you touch the cervix, does it bleed? So it kind of indicates that it's a bit friable. And if you can see an obvious mass when you do a pap smear, obviously you're going to refer straight away. You're not going to wait for that pap smear to come back. In terms of the spread of cervical cancer, so it can spread into the parametria locally, which is essentially just the tissue around the kind of top of the vagina and the cervix. Can spread to the bladder, the vagina and the rectum, to the pelvic and para-aortic nodes, and distally, distant metastases to the liver and lungs. Okay, so in terms of management, if it's early micro-invasive disease, so you've just kind of got a few cells invading across the epithelial lining, then it can just be a cone biopsy or excision. So essentially the same as the way you would treat a high-grade intraepithelial lesion. If it's stage 1, you do a radical hysterectomy with a pelvic lymph node clearance, which is different to a total hysterectomy. I'll show you a picture in a second. And pelvic radiotherapy. And again, stage 2 to 4, so if there's node involvement or distant metastases, it's radiotherapy with chemo. So I thought this was a good diagram kind of showing the different types of hysterectomies. So subtotal, which is not very commonly done anymore, but is essentially taking out the uterus and leaving the cervix behind. So obviously people that have that still need to have pap smears. Total is taking the cervix and the uterus, and radical, which is what you do for cervical cancer, is taking the uterus as well as that parametrial tissue, which you can invade into locally, and the top or higher part of the vagina. Okay, I think this is the last thing. So ovarian cancer. So this is the most deadly gynecological cancer due to the really vague kind of presentation. So it's often diagnosed quite late. The peak incidence is around 55 to 60 years old. So often it's picked up late as an incidental finding on pelvic ultrasound or a CT abdo or pelvis performed for another reason. But they can present with this IBS type presentation. So they get bloating, kind of non-specific abdo pain. They feel like really full, which goes with the bloating, and they might have some diarrhea or constipation. On examination, you would say that you would palpate the abdomen, feel for any mass. You might, if they're distended, you would test for shifting dullness for ascites, and you would listen for any, and percuss for a pleural effusion, and you would palpate the neck and groin nodes to see if there's any nodal involvement. So with ovarian cancer, there's this thing called the risk of malignancy index. So essentially, this is when you find a cyst or mass on the ovary of some sort on pelvic, say pelvic ultrasound. And this is kind of a calculated risk of how likely that cyst is, how likely it is to be malignant. So this uses the ultrasound findings as well as the menopausal status and CA125, which is your tumour marker. So, and you multiply those together to calculate your score. So for menopausal status, if they're postmenopausal, they automatically get 3 points. Premenopausal is just 1 point. For ultrasound, so the features you're looking for are multilocular cysts, solid areas, bilateral lesions, ascites, and intra-abdominal metastasis. And depending on how many of those you get, 0, 1, or 2 points. And then the actual level of the CA125. And so you multiply all those together, which gives you this score, and which is translated into kind of the risk of cancer. So obviously kind of moderate to high risk, you're more likely to do further investigations. In someone who's premenopausal and it's just a simple cyst and no other features, you wouldn't be as worried, and you would maybe just redo a pelvic ultrasound in a few months to make sure that it's gone away. Yeah.
With the ultrasound, is there no abdomen usually multiplied by 0?
Yeah. So like if there's no cyst there, I suppose that's saying. Like, yeah. Yeah, so which was just 0 then, isn't it? But yeah, good point. Yeah. So if it's a simple cyst in a premenopausal woman, you probably wouldn't even think about this. Yeah. So in terms of spread, the most likely place for ovarian cancer to spread is to the other ovary. And it can also spread to the mesentery and the uterus, and have metastatic spread to, the lungs and the liver. So again, you do all your normal cancer staging tests, so FBE, UEC, LFT, and your chest X-ray because it can spread to the lungs, and a CT chest abdo-pelvis. Obviously, if you're doing a CT chest, you probably don't need to do a chest X-ray, but those are the things you would consider. So for the management, as I said, it usually spreads first to the other ovary, so you wouldn't usually take the risk. So you would do a bilateral salpingo oophorectomy as well as a total abdominal hysterectomy. And an infracolic omentectomy, so that's just taking out the omentum below the colon, and a lymph node resection. You can do primary chemo, so that would be in someone with a later stage of disease that you might not be able to operate on, or you can do adjuvant post-surgical chemo. Any questions about that? Cool. So we'll finish with just a few quiz questions. So, do you guys want me to read it out, or are you happy to read it? So Mrs. M is a 45-year-old heavy smoker complaining of heavy menstrual bleeding for the past 4 months, and there's no cause found on investigation. Which of the following management measures would not be appropriate? Yeah, good. So because she's a smoker and she's above 35, you wouldn't want to give her the pill. Okay, so a patient with long periods of anovulation is more apt to suffer which of the following types of cancer when compared with a woman who has regular cycles? Yeah, good. Can you explain why? Yeah. Yeah, and so if you have unopposed estrogen, you get endometrial proliferation, so which can cause endometrial hyperplasia, which is a risk then to go on to become endometrial cancer. So a 32-year-old woman with severe cyclical abdominal pain and primary infertility. So she's been trying for 24 months and hasn't got pregnant. What is the most likely diagnosis? Yep, good. So So an ectopic is usually more acute, wouldn't explain cyclical abdominal pain. Fibroids can cause infertility if they're quite big, but usually wouldn't cause abdominal pain, especially not cyclical. Ovarian cancer can cause abdominal pain. You wouldn't really expect it in someone of reproductive age anyway, but it wouldn't necessarily cause infertility. It's not primary dysmenorrhea because it's only really just started, although it doesn't really specifically say that. And it's not adenomyosis because that doesn't cause infertility and it usually causes heavy menstrual bleeding. So Mrs. W is 35 years old. She had a pap smear and it came back as a high-grade lesion. What is the most appropriate management option? Yeah, so refer for colposcopy and biopsy. So Miss J is 27. She also had a pap smear, and while taking it, you notice some vulval warts, but her pap smear comes back normal. What is the most appropriate management option? Close.
Last one there.
Yeah. So you just repeat this pap smear in 2 years. So can you explain why?
I forgot to see that. It was done just a week prior.
Yeah. And it came back normal. So like we said earlier, the strains that cause the vulval warts are not the same as the strains that usually cause cancer. So you could treat her vulval warts, which is usually like a like diathermy or something like that, like you burn them off. But in terms of pap smears, it doesn't matter. It was normal, so you repeat it again in 2 years. I thought there was another question, but there's not. Okay, so that's the end. So just what I haven't covered, didn't really cover dysmenorrhea in any great detail. So make sure you know endometriosis and PID, both in terms of dysmenorrhea and causes of infertility. And I think just 2 things to be aware of, I don't think you really need to know much about them, is gestational trophoblastic disorders, or you might have heard of molar pregnancies. So they're kind of conditions in which you get a growth, which often to start off with you think is a pregnancy, but it's not actually properly fertilized. So read into that. It's interesting, but probably not essential. And I didn't cover vaginal and vulval cancers. I think no, they exist. They're carcinomas. Vulval cancers are SCCs, but they're rare, so I wouldn't really worry about it too much. Any questions? Cool. Thanks for coming along, guys. Hope it was helpful.